Bonjour à tous, merci pour être ici. Il s'agit du dernier jour de notre congrès et nous sommes un petit peu marginalisés, on pourrait dire, parce que nous sommes un petit groupe dans le sous-sol, nous sommes loin des activités principales, mais nous allons parler d'un sujet très important. Nous allons parler d'autres communautés sérieusement marginalisées qui souvent sont laissées de côté quand il s'agit des ressources parce que quand on parle des zones urbaines, on peut assumer des fois que l'accès aux services est bon, mais la réalité c'est qu'il y a souvent des barrières et des ressources limitées. Alors, nous sommes un groupe petit, mais je pense que nous tenons vraiment à cœur cette question. Et nous avons deux orateurs ici, deux autres orateurs qui vont nous joindre par vidéo. Je vais me présenter. Je suis nommée Fix McCammon. Je suis vice-directrice à la fondation Melinda Bill et Melinda Gates. Nous nous concentrons sur les populations urbaines pauvres. Nous cofinançons cet investissement avec Bear et il s'agit vraiment d'une plateforme, peut-être vous la connaissez. C'est une plateforme donc, qui essaie de fournir de l'assistance technique basée sur la demande aux gouvernements locaux pour développer la planification familiale. Alors, j'aurais envie de vous donner l'opportunité de vous présenter vous-même. D'accord? Nous sommes un groupe petit, comme déjà dit, mais nous pensons que les petits groupes peuvent faire vraiment des choses importantes. Ben oui, qui sait qui va résulter de notre discussion? Alors, je vais commencer par la salle. Nous allons nous présenter, nous allons savoir pourquoi nous sommes ici. Ensuite, je vais passer la parole aux orateurs qui vont également se présenter. Merci, bonjour à tous. Je suis Abhijay Kumar, je viens d'Inde. Je travaille avec le Population Council et je travaille dans le domaine de la planification familiale, dans le domaine de la santé sexuelle et reproductive. J'ai une présentation que j'ai présentée le 15 novembre. Justement, on travaille autour des services fournis aux jeunes entre autres. Bonjour, je suis Dr Mujumdar. Je travaille également à Population Council. Moi aussi, je travaille dans le domaine de la planification familiale et de la santé de l'enfant. Merci, bonjour à tous.
Pharmacist Mrs. Emily Olalere from Nigeria. I'm from the national regulatory body in Nigeria, the Pharmacy Council of Nigeria. I'm here at this conference. We have an innovative pilot on what we call the 3-tier accreditation system. We have a group we call the patent medicine vendors, equivalent of a drug shop. We are piloting the stratification of that group, and it has been a very wonderful experience in Nigeria. Thank you.
What? Oh. Hello, good morning, everyone. My name is Ayelio from Ethiopia. I'm Executive Director of Organization for the Development of Women and Children in Ethiopia. Thanks.
Good morning, everyone. My name is Dr. Sheikh Sarr. I am Executive Director of Social Marketing Agency in Senegal.
Good morning, everyone. My name is Tonya Komalafe. I work with Population Council in the Nigerian office. I have a presentation after this. Thank you.
Yeah, good morning, everyone. My name is Dewi. I'm from Indonesia. I actually work in the University of Indonesia, and actually I'm here to support my colleague that will be present, but she will present online via video. So yeah, just want to watch the presentation.
Hi, everyone. My name is Anupa Gewali. I work with a Planned Parenthood affiliate in the greater Northwest, Hawaii, Indiana, Kentucky. I'm based in Seattle, and I'm part of the Global Programs Department. We have partners in Vietnam, Nepal, and the Marshall Islands.
Yes. Good morning, everyone. I am Dr. Marem Janjai. I am the Chief of Family Planning Division in Ministry of Health, Senegal. Thank you.
Hello, everyone. I'm Hadi Sek, advisor in a project. The project in Senegal is an health district, integrated health district project. And I work there as advisor in reproductive health and nutrition. Yes, thank you.
Okay, thank you, everybody. For those of you who walked in, I deeply appreciate you taking the time to introduce yourself. Everyone in this room has really incredible expertise and diversity of ways in which you're engaging with the ecosystem. So thank you for being here. I think we can all say, no matter if we're in Senegal or Nigeria or India or Indonesia, and even for us who are supporting from the Pacific Northwest, that we know that donor financing is quite limited from Ethiopia as well. And I was saying at the beginning, particularly for the urban areas, sometimes we've over-rotated as donors. And I personally have worked, I work with the Gates Foundation now. I've worked with USAID and the State Department. Sometimes donors are very focused on rural areas and tend to forget what's happening in the urban settings. Particularly for the urban poor, there's a degree of marginalization that happens and an expectation that urban healthcare systems and infrastructure are strong enough and don't need assistance or support. I think we'll hear today with our commitment to the SDGs and leaving no one behind, that paying attention to the urban poor is critical for our national and global goals, and from a humanitarian perspective, a really essential part of addressing unmet need. I'm interested in innovation and scale, and how might learnings from different geographies help to improve our efficiency in reaching the urban poor. So with that, unless we're very informal. We've said, for those of you who just walked in, that we are a marginalized group here in the basement on the last day of the conference. If you want to give a quick hello, everyone's introduced themselves, and then we'll turn it to our first presenter, Mike Mbizo. But do you want to say a quick hello?
Hi, everyone. My name is Claudia Brewer. I work with an organization called Male Contraceptive Initiative, but I'm also a student conducting research on sexual health literacy.
Sorry. Hi, good morning. I'm Julia Bunting, President of the Population Council.
Okay, we have a strong Population Council representation here in the room with a lot of robust research. So maybe over to you.
Okay, thank you very much, Naomi. My name is Mike Mbizo. I am Country Director for Population Council based in Zambia and a Senior Associate. But I've also served and tend to wear a number of hats. I've been a Director for Reproductive Health and Research for the World Health Organization based in Geneva. But I really like to say I am a sexual and reproductive health advocate. And I believe this is an agenda of interest to many of us who are in this room. Thank you.
So good morning, everyone. I'm Dr. Subroto Mandal from USAID India office. So I am a researcher as well as monitoring evaluation specialist in the organization. I worked on the health sector for long, almost 35 years, but then most of my career I have actually spent working very focused on urban areas, not only family planning, but dealing with many others domain of health. So therefore, it comes within my natural passion for this group, and then for we want to see more that what is happening, even if I am in USAID and working differently, but still mind goes there. Thank you.
So good morning once again. It's really a pleasure being here to share in this important topic. I'd like to acknowledge my colleague, Dr. THUR, who could not be here, but we are from the same family within the Population Council, so I was very happy to be coming and standing in for him. The team has done tremendous work in terms of scoping literature to look into the urban environment and disparities that prevail within sexual and reproductive health, looking at the outcomes in the Global South. So we will be discussing and seeing what the situation is like. So we know that, maybe I'll use this. I like walking. So we know that we have environments which our chair lady just mentioned in terms of urban environment, and there are estimates that go beyond the current, where by 2015, the estimation is that up to 60% of the world's population would live in urban areas, and much of this will be representing the growth in the Global South. This has a bearing, in particular, amongst the urban youth, whom we know tend to have a high unemployment rate. Their young age makes them fairly vulnerable. And increasingly, we know that these are females. And we are all aware in terms of some of the high risks that the females encounter. So more than half of women, unfortunately, tend to live in slums, according to the recent study of 38 countries, and the sexual and reproductive health sector, which really is the community in here for this conference, really needs to adapt to these urban contexts so that we are not just responsive, but we can anticipate and plan accordingly. Oops. Okay, so if we look at the MDG framework, we can see the intersection within the MDG framework and the call within each of those in terms of having sustainable cities and communities, the issue of gender equality, which is really coming up very strongly in these days of equity. The issue of good health and well-being as amongst the key issues that underpin economic development or sustainable development. Affordable and clean energy, again, an issue versus, which is coming up even more strongly in the context of climate change. Industry, innovation, and infrastructure. So we can see the intersection and the need to be responsive to some of those. Okay, so between cities and within cities, there are disparities. Urban residents have much better health indicators than those in the rural. However, not much is said about those that are in slums within the urban environments. And inequitable distribution of resources and advantages in the urban environments, that tends to create some of these disparities that are encountered in sexual and reproductive health. If we look at the issues of gender, gender-specific challenges, issues of safety, issues of income disparities, and persistence of harmful gender norms. So what we see in our environments and what we grapple with within our environment tends to be exacerbated when you have communities which are in those environments. So you really are talking of the marginalized, of those that are most vulnerable. And that's where the challenges are heavy, and that's where the commitment in terms of literature is underpinned by. So the scoping literature was really to look into the literature in terms of that which has been peer-reviewed, as well as the gray literature. And this focused on literature from 2010 to the present, looking into the sexual and reproductive health and rights issues. And what we have is a narrative synthesis of the approach that was used within a study to describe the current body of evidence on sexual and reproductive health within those settings, and to try to distill the granularities when it comes to these disparities, and thus highlight some of the emerging or promising approaches towards improving sexual and reproductive health and rights outcomes, with a view to mitigate the disparities. And so within that review, this is, once we get the picture, if we contextualize and we are all together within this kind of environment, what is it that emerges? And so the scoping actually covered quite a number of articles. As I said, peer-reviewed articles as well as the gray literature, with up to 91 articles which were identified, looking at the key indicators that relate to family planning and HIV, 25 and 58. But just to see in terms of, we know about the outcomes in family planning, and we know about the outcomes in HIV, and we know the extent to which they become even more manifest when it comes to issues of disparities and exacerbated environments. So the majority of these is really focused on the individual level factors. What is it at the individual level we can identify and describe, and look at the contribution. So these are classified into a few domains, and I'll relate to those domains. The first one being the structural environment, housing deprivation, overcrowding, poor quality, instability, issues of safety, exposure to harassment and violence, which tends to be exacerbated when people are crowded within that structural environment. Issues of concentrated poverty, when people start to feel that there is nothing beyond what they have at the present, and how that creates instability. Issues of equitable access to services. Do people have the transportation to access those services? What are the costs? Are they affordable? And are they stigmatized when they get to those facilities? And the other domain is that of the policy environment. Is the policy environment conducive, for instance, to the well-being, to the health, to the growth and the economic realization of the potential which some of the people may have, even if they are within that environment? And to what extent does that environment compromise attainment, full attainment of one's potential? So governance issues from a social perspective, economic perspective, political exclusion within the slum communities. At the national level, at times we have restrictive laws which tend not to be enabling when it comes to some of the risks, for instance, associated with unsafe abortion. At the global level, we also have disconnect or disconnection between human rights frameworks and the lived experiences, because at times these are really theoretical frameworks, and those theoretical frameworks should create an enabling environment. They should really set the track in terms of moving forward, but the reality on the ground tends to be different. So that's within that domain. And so what are the interventions? Just looking at the interventions, you know, there have been some holistic programs, behavior change approaches, communication strategies. The literature looked into some of these interventions to try to see the extent to which they've been facilitative and they are making a difference. So facility-based strategies, what are they? You know, within the urban environment, what are the initiatives that are likely or making a difference in that context? So, from that literature, what are some of the takeaways? Standardization of measures, measure and address some of the structural determinants. I mean, this is coming out in terms of what needs to be done. There is that saying which says, if it's not measured, if you do not have data, then consider it not done. And so we need to be measuring and address some of the structural determinants of health, which include those that are marginalized and those that are in that environment. Include the perspectives of all urban residents, particularly those within the most marginalized areas, so that their issues are taken into account, their contexts are taken into account in terms of equity. You know, I've always said, you know, at times we mask data. At times, globally, we have targets which we live by. We have targets, and we can say, one very good example is the 90-90-90 global targets. We all know about the 90-90-90 in HIV, which have moved to 95-95-95. However, when you disaggregate the data, I mean, many countries report and said, oh yes, we have attained the 90-90-90 targets in terms of knowing the status, suppressing, and being committed to taking antiretrovirals. But when you stratify and when you disaggregate the data, you actually see very often that it's the adolescent girl and the young woman who is most affected, who is nowhere near those targets. And it gets worse when you look at those that are in that environment, in those environments, in the urban slums, in the rural areas, those that are marginalized. So we need to identify key stakeholders who can work and build effective and sustainable interventions. We need to leverage the urban environment in the designing of those environments to ensure that they can be responsive and they can indeed be part of the solution. I really would like to thank my colleagues, Jesse and THUR at the Council who put this work together, but to also appreciate your commitment by being here and being able to identify with the plight of those that are most marginalized. I thank you, Madam Chair.
Working either, yes, okay, great. Hi, friends and colleagues. We all introduced ourselves at the beginning, so I know some of you have come in a bit late. You're very welcome. We are assuming that you are all committed to the urban poor, and we're looking forward to a robust conversation. Mike, thank you so much for that. In just maybe a quick summary, and we'll be able to tie some themes together before we move to the next presenter. So if you do have questions, I'm going to ask that you jot them down briefly. We're going to run through all presenters to make sure that we have adequate time. We have some individuals on video, and then we'll open it up for questions and discussion. It's great to see you, Amy. But just, I think a couple of the key themes that I'm taking away from the presentation and I'm sure we will hear this, it's a great scene setter, is the amount of growth that we know will happen in urban areas. These are large projections, and they're multifaceted. It's not just large numbers of individuals. These are young individuals, primarily female, who face a multitude of barriers. And this is something that's critical that we need to keep in mind around the magnitude of the problem. We also then talked about structural determinants and the need for measurement. And I think we have the magnitude of the problem. I'm anticipating that when we go through each of the presentations, measurement will be a key issue, as you said, Mike, that if you don't measure it, it doesn't get done. We seriously lack standardized measurements in our field. And I think that this has harmed us in terms of looking at some of the root causes. And one of the areas that I greatly appreciated that you talked about, which is the third point, is the particular gender inequities that show up. You talked at the end about involving essentially the users, the people that live in the community in terms of identifying solutions. So often when we talk about reproductive health, we're forgetting about those safety concerns or the economic constraints that particularly face young women. And so as we move forward throughout the discussions, the issue of gender inequities is something that I think we'll all keep in mind as we identify both issues and potential solutions for these very marginalized communities. So with that, I'm going to turn it over to my colleague Subroto, who will talk about his work in India. Thank you.
Thank you. So good morning, everybody. Thank you very much for coming here and listening to this very important issue that we are talking about urban poor. I remember that when we are talking about MDGs and now we are talking about SDGs, one thing came to our mind that predominantly our focus is in rural areas, but at the same time, urban population is growing and is growing, and it will continue. And you have seen, it is a great scene setter for this presentation that in what perspective we are talking about when we are going to have 60% of our population in urban areas. So therefore, it is very important to focus early on in urban areas to understand what is happening. Now, so what we saw in India way back in 2000 that is predominantly our government focus is in rural areas, and therefore urban sector is really neglected, and people are thinking that we have private sector is providing services to urban population, therefore people will take care of that and services will be taken care. But it was not true in that sense. And then we started working in urban areas in 2002 from USAID India. And then Gates Foundation joins in India because India is a huge country where it's unmanageable if you really don't think that it is, everybody is not working together. So from that perspective, it is very important when you are saying that no one should be leaving behind, and then if you are not touching this 1/3 or 30%, 40% population who are staying in urban areas, and more so, out of that, another 40% is really staying in urban slum, that what Michelle said. Now, if we are really not thinking about those people, then how we will think about you will achieve the MDGs or the SDGs goal. So therefore, your maths will not work at all. So you have to think about, you need to really reach out to everywhere. Now, so from that context, so in India, we started urban health programming, and then it was a just donor-funded testing that what is the scenarios in urban areas. And then therefore, it shows that there is a huge need to really program on urban areas, and only donor cannot really help much. And then therefore, advocacy started to work with government. And I remember in 2003 13th government recognized that there is a need to work in urban areas, and then therefore along with the National Rural Health Mission, they came up with National Urban Health Mission. And now this is a combined national health mission. So urban and rural is given equal emphasis. But still there are some challenges. So we'll talk about that. And also we wanted to see when you are really given a late emphasis in urban areas, and also in the natural process, private sector is flourishing in urban areas because of this business and their own interest. It is very important to understand whether inequalities in increasing or not in urban areas. If inequalities you are not able to address, then therefore you will not be able to reach the SDG target in that matter. So therefore we wanted to test that from our research. And this is a effort from USAID India through Population Council to support Government of India to guide them that how their program is really working in the field, what is the focus area they need to really think on, and also in which areas we are doing well and which areas we need to really focus further. So we started with the hypothesis that to what extent socioeconomic inequalities in family planning indicators widened or shrunk, whatever. So we'll see that in past 30 years in urban India. And does this inequality vary by type of family planning indicators? This is also very important because we know that some methods promoted mainly by public sector, and some methods promoted mainly by private sectors. Private sector have their own interest to promote that. It's natural. And does this private sector service provision enlarge socioeconomic inequities in family planning indicators in urban areas? So we wanted to see that because this is very important. If we don't see this and see and check it, then we will have a problem in reaching out the goal of SDGs. So to do this, what we have done is that we have used National Family Health Survey data from 1992, the first round, and also the fifth round, 1991, 1921, 1919 and 1921. So this is recently finished. And we used for this analysis currently married women aged 15 to 49 in urban areas. And what are the outcome variables we have looked at? Modern contraceptive methods prevalence rate, use of non-reversible method, use of modern reversible method, and demand for family planning satisfied by modern method. And key predictors we have used household wealth quintiles. So this is calculated from standard of living component, index component. And also we have also checked whether this varies by women's schooling or education or not. Also see source of services, whether it is public sector or private sector. So there are a small component that we have not really taken into account. This is others, which is NGOs or particularly when husband buy something, they don't know really from where they are buy or procured, buy or collected from public sector or public sectors. We do not know, so that we have really excluded from the analysis. This is a very small one. Now, statistical analysis, what we have used is simple univariate analysis to see the levels and trends. And also, we used concentration curve and index to understand what is the extent of inequity exists in urban areas. And to see whether what we see from this two, whether that holds true when we really see in a rigorous statistical regression analysis to reinforce that what is coming from this analysis. So coming to the findings, Now, I'm not going through each and one of each slide and each graphs, but what is important message is that now over a period of time, we see that the inequality gap among poorest poor and rich women is really narrowing down over a period of time. And also, I wanted to tell you one more thing, that in India in 2002, USAID and also later on BMGF started urban health programming. And after that, around 2013-14, I said that government of India taken a full note of it and started urban health mission in the country. And I think that is really reflecting here when it started showing that inequality is increasing because of urban to rural to urban migration, and this population is coming, and also that there is a gap, but because of this program, I guess that is really reflecting here to show that this gap is really narrowing down over a period of time. But still there is some gap. I think that is really good to see here. Similarly, when it use of reversible method, the same scenarios is emerging here. Is that gap is narrowing over a period of time. So I think this is almost equal in terms of in the inequality point of view. But still there are some things, some work needs to be done when we talk about poorest of the poor in the last mile. There are some gap really, and we'll talk about it. Now, so when we see whether the same kind of scenario we see among educated and non-illiterate women in urban areas. Now here we see a mixed one. Sometimes we see that this gap is really wider among educated women versus illiterate women. Now, and this is quite interesting that when we talk about use modern methods, gap may not be much, but when you see that non-reversible method and reversible method is quite opposite. We need to understand that why it is opposite, because when we talk about some reversible method, now reversible method, if you see that those who have higher the 12 plus education years of schooling, so they have a higher prevalence than the illiterate one. But when it comes to non-reversible method, so then it is the opposite. Now this showing that women from illiterate category are adopting more and more non-reversible method than other category. And when it comes to reversible method, this is quite opposite. Okay. So, so when it comes to inequality and concentration index, now what we see is that both wealth and education-based inequality has reduced over a period of time. Still, we see that inequality is higher for use of modern reversible method, indicating that that prevalence is higher among wealthiest and educated women than their counterparts. So this is the main message here. So we see that is quite, so this slide is very important. Now here we see that the way women access contraception from private sector, or the way private sectors fix their target audience. Now you see when it comes to public sector, inequality is much less because public sector do not really think about any target. Anybody can come and access it. But when it comes to private sector, so they really target and then provide all this advertisement and communication, so that those who have paying capacity will be able to really purchase that. And that's why we see that there is a gap. But when we see that overall women, whether this is any inequality exists or not, you see in the middle gap, actually it is not. But when somebody is filling the gap, so I think this is why it is very important. Although apparently we see that in private sectors, gap is showing much higher and over a period of time, so it is reducing. But there is gap exist, but it doesn't matter. Overall, it is really inequality is reducing. I think I'm not going because of time, but what is important is that we wanted to see this in urban areas only, but we want to extend this in the, because India is a big country. We really need to understand whether what is happening probably in the northeastern states where this is really not accessible by everybody, but extent of urbanization is very different in different states. And also whether this similar gap actually exists in rural and urban by wealth quintile. It's very interesting to see, and also is a good to do this analysis for policy perspective to understand under SDG arena how we are in this family planning space. Now, the key message is that now we see that gap is really reducing, so we are really not worried about SDG targets in terms of our maths, but what is important is probably, so our strategies are working, but one thing we need to really do is that increase the coverage. Now, so we always worried about marginalized communities, but here it is not the case, but actually we need to increase the coverage across the country and across the wealth quintiles and across the population, across the socioeconomic group. I think that is very important. I think that is the big message for the government. And I truly acknowledge the support of Population Council and my friends here, Abhishek and Arupendra, they are also co-authored. So they are actually doing the major work, and I am also, on behalf of them, I am presenting it. And also is a disclaimer that this is really not the views of USAID, India, and US government. So this is the view of our authors, and this is it. Thank you. Thank you very much.
Subrata, thank you so much. That was fascinating. I think it's rare for us to get a data set from 1992 through 2021 that's incredibly rich information and really fascinating findings. I'm guessing I had some questions around quality of care and discrepancies. So I'm hoping that we'll have some time to dig into that. I think we are seeing some themes even from what Mike presented in terms of the poorest of the poor, the most marginalized, and also another area that might warrant further discussion is the kind of almost like a total market approach. How are public and private sectors working cohesively together, and where are their opportunities? So we are all about equity here, and we want to make sure that every presenter gets their time. So we'll move on. We have a presentation from a colleague from the Ouagadougou region in Burkina Faso, and then we'll move to our last presenter from Indonesia, and then we will have time for some questions. So thank you all for being patient and for participating in this session.
Bonjour. Donc, j'ai le plaisir de présenter ma communication sur...
Good morning. I have the pleasure to do my presentation on the migratory status and modern contraceptive use in Ouagadougou. Sorry, we could not be present in this major meeting, but then we thank you all, the audience, for listening to us online. So let's talk about the presentation plan. And we are beginning with two observations. The first observation is with regard to the development of modern contraceptives in the city of Ouagadougou. And we realize that there are two major phases in this development or evolution. The first phase is the increase in contraception use in 1990s to 2010. And then the last stage, which is the stagnation period from 2010, which does not move. And the second observation that we can make is that the population increase of Ouagadougou through the latest census, we saw a whole strong concentration of population in Ouagadougou. And this increase in population is linked with immigration. And then in this immigration, we have a high presence of women. So the idea was to see whether stagnation of modern contraception in the city of Ouagadougou has been fed by certain measures as a result of the stock of migrant women who arrive in the city of Ouagadougou. And then also this renews the stock of women for a profile to lead them at a global level to observe an entire situation on contraception use. So from these questions, we have three specific questions. Let's look first of all at the profile of women, and that is according to their migratory status, to see whether they have the same profile or not in terms of socioeconomic values. Then we look at what is the effect of the duration of residence of migrant women from rural areas on their use of modern contraception. And after that, we'll look at whether this effect vary according to the various neighborhoods, because we have certain planned neighborhoods and unplanned neighborhoods. Now, what about the data and variables? Now, we had the observations of the population of Ouagadougou, and this would allow us to answer these questions. But then we have a dependent variable, that's the use of modern contraception by women by the time of the survey, and then also the main independent variable, that's the migration status, as well as the three categories that we distinguished in the question of the duration of residence in Ouagadougou. And then also we use other independent variables that are classical, and to be able to check when you are studying the determinants of the contraceptive use. And in this inquiry or survey, we had data on various social lives that we checked on our analysis. Now, method of analysis, we use descriptive analysis, where we try to look at the profile of women to see whether we have any classifications or typologies. Then also looking at the various cross tabulations between the use of modern contraception and migration status. Then multivariate explanatory analysis to see whether the migratory status on contraception was working. So we had to strategize this model with all the various women, but then we distinguish equally the women from well-planned neighborhoods, and then especially and the others, the planned areas that have a lot of facilities and so on, as against the unplanned ones. So when it comes to the profile, we see here that there is a difference. For the non-migrant women, they live in the various planned areas, and we have a lot of families. And then also we have the migrants that are plus 20 years. And then also with the formal areas, we have rich families or rich households. And then we also have the migrants, migrant women between 10 and 19 years. Here, majority of them are in unplanned or non-endowed neighborhoods. And then also those who have arrived for less than 10 years now also equally are in the great majority in their neighborhoods that are unplanned, and they are of very poor households and are not well educated. But then when you look at all these products and the data, you realize that in the unplanned or informal areas, we don't have a lot of differences. But then when it comes to contraception use, we see a very low use of modern contraceptions with women who have migrated newly. And so this is about 2 times less with regard to those who are there for more than 10 years. Now, we look at, now this is a graph which actually shows us what has just been said. Then, when you look at all the variables, this is with the entire gross effects, with about almost 50% that are not using modern contraceptions. And then we try to check that with all the determinant variables, women who have migrated recently to Ouagadougou have 50% less opportunities than those that have been there longer periods. And then when you look at the residential areas, the informal residential areas, the rate is quite persistent, especially in the non-formal areas or the informal areas. But then in the formal neighborhoods or areas, the difference is the same. Now, what is the contribution of research of this particular study? Now, this research has brought a clearer situation on the status, and especially on the use of contraception, and brings out the intra-urban inequalities in terms of contraceptions. And then beyond that, we also have urban inequalities on the issue, especially brought to note or brought to the knowledge of all. And it's rather women who settle, the recent migrants who settle in the formal or informal areas, and then also they take advantage of the use of contraception methods. So this category of women constitute mainly a target group to whom the commune of Ouagadougou can be interested in if they would like to boost the use of modern contraception in the city of Ouagadougou. You know that in Ouaga, we have this issue of free service that is used. But then these products shows that we can have services of access to family planning for people who live in these areas to be able to have easy access to these contraceptive methods if they need them. But then if the services are not in these particular areas, then of course we will see that there is a free service. But then there are greater part of women who have recently arrived and then reside within the extended or the outskirts of the city, but then who are still interested to be able to use it and also resolve the problem of contraception. I thank you very much for your kind attention.
Health services use and quality had contracted during HETNET. Morning, I'm Elvira Lianto, Program Analyst for Maternal Health at the UNFPA Indonesia. Morning, I'm Elvira Lianto, Program Analyst for Maternal Health at the UNFPA Indonesia. Today, I'm going to present the study that me and my team conducted on how well are Indonesia's urban poor being provided access to quality reproductive health services. The UN projected by 2050 that 2/3 of the world population will be in urban area, with additional 2.5 billion people living in the cities, and majority of whom will be concentrated in cities in Asia and Africa. The proportion of Indonesia citizens living in urban areas will reach 70% by 2045. Therefore, understanding how urbanization is affecting access to and use of reproductive health services are important for Indonesian public policy. A major challenge for governments to adapt vital public services and social protection system to meet rapidly growing urban demand, particularly those in urban slums. Data show people living in urban slums experience social, economic, and political exclusion, have weak social networks, which in many cases bars them from society's basic resources and have limited access to health insurance. They face much greater challenge to improve their health than other parts of the countries, despite living in relatively close proximity to the health services. The objective of the study, we assess how being from urban poor or near poor households affects the quantity and quality of family planning and maternal health services received, and the extent to which differentials have narrowed during the 2012 to 2017 period. Source of data were the 2012 and 2017 IDHS with population of married women of reproductive age, current contraceptive users, and focus on the last pregnancy reported by respondents. We are using two stages of analysis. First, we examine differentials in family planning and maternal child health related behaviors and service utilization. Then, we assessing whether urban poor versus non-poor gaps in reproductive health services use and quality had contracted during the 2012 and 2017 period. This time interval is significant due to the introduction of a National Social Health Insurance Scheme, or JKN, in 2014, establishing the foundation for universal healthcare in the country. The contraceptive prevalence rate in urban areas was 63% and the MCPR was 55%. These relatively high figures mask the fact that contraceptive use rates have been stagnant since the turn of the century, and levels of unmet need for both family planning and for modern contraception remain moderately high. This figure here showed comparison between poor and non-poor urban women, where it showed that both poor and near-poor women had lower levels of contraceptive knowledge. No sizable differences are observed in terms of informed choice, contraceptive prevalence, or unmet need for family planning. The poorest women were, however, less likely to have been using traditional or permanent modern contraceptive methods. This next result is quite shocking for maternal and child health services. Data suggests that the quantity and quality of ANC and birth delivery, and to a lesser extent, postnatal care services received by poor and to a lesser extent near-poor women were inferior to those received by non-poor women. More or less across the board, women from poorest 20% of households were more than 2 times more likely than non-poor women to have had below the full sample average number of ANC visits, 9 times more likely to have ANC services provided by a traditional birth attendant or TBA, over twice as likely to have fallen below the full sample mean with regard to numbers of days of iron supplementation, more than 3 times more likely to have delivered at home, nearly 4 times more likely to have delivery assisted by a PBA, and nearly 3 times as likely by a relative or friend versus a doctor, and 28% less likely to have had an initial postnatal check within 1 week as compared to the non-poor women. Time effects for selected family planning outcomes for urban versus non-poor, urban poor and non-poor women. The time effects for non-poor, poor and near-poor women for selected family planning indicators are shown in this table. The trends for the poorest women were more favorable than those for non-poor women regarding informed choice or method information index, contraceptive use, and unmet need for modern methods. Poor women gained ground regarding contraceptive method knowledge and informed choice at the time of contraceptive method adoption that may well be linked causally. The only statistically significant change in family planning indicators observed for non-poor women was an increase in unmet need for modern contraceptive methods, which was the result of the increasing use of traditional methods by more educated, higher household wealth women, and this might be due to fear of side effects. For family planning, the level of contraceptive use and quality of services received by urban poor and near poor women did not differ markedly from non-poor women. This trend between 2012 and 2017 was encouraging. Regarding maternal child health, statistically significant 2012-2017 changes are observed among non-poor women on 6 outcomes. Positive trends are observed in terms of number of ANC visits, months of pregnancy at first ANC visit, number of days in which iron pills were consumed, delivery by skilled birth attendants, and having initial postnatal check within 12 hours of delivery. A negative change was observed in terms of having an initial postnatal baby check within 2 months, and statistically significant differential changes are observed for both poor and near poor women. Poor women gained ground on non-poor ANC and delivery services by SBA, and gain ground with regard to post-delivery maternal checks within 12 hours as compared with non-poor women. The proportion of near-poor women receiving ANC service from midwives also increased more rapidly than among non-poor women during the observation period. Urban poor women, and to a lesser extent the near-poor, systematically lag behind non-poor urban women in terms of both the quantity and quality of maternal health services received in connection with the recent pregnancies. However, statistically significant gains were observed for all urban women, with larger gains observed for poor and near poor women on some indicators, likely associated with the introduction of National Social Health Insurance Scheme, or JKN, but large poor non-poor differentials still persist. We conclude here that the family planning needs of urban poor and near poor women in Indonesia appear to be being relatively well accommodated. This is not the case for the maternal and child health services. A difference between family planning and maternal child health results explained by historical differences in program effectiveness and greater reliance on private providers for family planning services. While the National Insurance Scheme appears to have increased financial access to services among poor women, further investment in public health sector supply side readiness and service quality is needed to further close the poor and non-poor gap. It is also noted that although helpful, the insurance scheme alone is unlikely to fully close poor non-poor differences in access to and quality of maternal and child services, since it doesn't cover transportation costs nor opportunity costs of long waiting times for services, and expansion of the enrollment puts additional pressure on public sector health facilities, which already suffer from supply side weaknesses. Further attention needed to a more flexible and accessible service delivery schedules and quality of services. To address this issue, greater collaboration with the private sector in the form of uniform minimum service standards will help reduce the burden on the public sector and government's funding needs to fulfill the demand for its urban citizens, including the poor. This paper has been published in April this year in the PLOS ONE journal. You can access the full paper there for more information and data. Thank you so much for your attention.
Excellent. Okay, we have about 15 minutes or so. So I'd love to invite audience members to either share a reflection or a question for the speakers. And one thing maybe just to kick us off, that's, I think we all know the data in terms of the magnitude of growth, but when you see so many presentations, it's incredible the need now to start programming, not just changes in programs or policies, but financing, as well as just urban planning. What we don't know is the extent of climate change or political instability, but we absolutely know for certain the population growth projections and the disparities that will come from that, and the harmful gender and social norms that may persist. So I'm actually leaving this session that there is a real call for action now at a global level for cities around the world to become ready now for those projections in the future. And so I just want to thank the presenters for really pulling together very compelling and thoughtful data to help educate all of us and for us all to get smarter as advocates for reducing inequities and supporting the most marginalized. So let me open it up for any questions or reflections from the audience.
Thank you. Again, really interesting and very thought-provoking. I guess a reflection for me was on the Ouagadougou presentation, which was really insightful. And particularly, again, we don't have our colleague to be able to ask questions of. I'd love to know if we can differentiate between that 0 to 9 group, because it's a really, 0 to 9 is a big group of people who've been recently migrated compared to then the 10 to 19 and the 20 plus, and there was a really big step, and I just wonder how long it really does take. Is it the first 3 years is really, really low and then it starts to grow pretty quickly, or is it takes you all the way through to 8 years and then suddenly? It'd be interesting to know what that curve is within that. Even if we can break down to the 0 to 4 and 5 to 9 or something, would be just fascinating. I don't know, again, who funded that research and who can do that further disaggregation, but I think there's something in there that needs to be looked at more than we saw from that presentation. But really fascinating to think about how do we support that transition. And I think it's both how do those receiving areas support the transition for people coming into them, but also where are they coming from and what could be done prior to the move that sets them up for success when they arrive. And I think we need to look at both sides of the coin.
Thank you so much. So I also have one query from the presentation from Ouagadougou. So the data is clearly showing that the migration has negative effect on contraceptive use. That is true, and that is also evident in our country as well. We presented something on that day before yesterday. But is there any evidence that whether other than the migration, does migration intensity affect the contraceptive use? Like the area from where the more male migration compared to the area where male migration is comparatively less, and how in these two geography the use of contraceptive is associated. Is there any evidence on that? Thank you so much.
Thank you so much for the presentations. I'm a youth advisor, so I'm coming into this with the youth lens in mind. And I know quite often our data doesn't necessarily capture the age differences. I don't know if the presenters who are here did do any age disaggregation in the analysis that was done of the differences between, those young women and men who are quite often the ones who migrate for their family's sake, often being sent out to send money home. And unfortunate that we can't speak with the gentleman from Ouagadougou as well, because in line with the question or the reflection that you had, does age have something to do with that 0 to 9 year time frame of not using contraception? And you sort of have this overlay of two different scenarios that impact contraceptive use or belief in myths and misconceptions or desire to prove fertility or fear of infertility. So yeah, just kind of anything that you saw if you did some age disaggregation in your work, or if not, where that might look in the future when we do continued research. Thanks.
I can probably, no, I think this is a really good question, and also we also acknowledge the fact that we have just analyzed from macro perspective right now to understand what is the inequality, but also we acknowledge that there is a need to really see the migration pattern and urbanization level, and also areas where we have social disturbance vis-a-vis age group. We try to see education by education, but age is definitely a factor. Probably, so that will be helpful for our team to really go much deeper and do the deep dive on those. This is possible because it supports the data we have used is demographic health survey, and that have disaggregated data. We can really can see that. That is possible. Thank you.
Thank you. Thank you. I think that's something which I emphasized, the issue of age disaggregated data. In that when you do that stratification, you can see the extent to which the ones who are in the lower age groups, especially girls, adolescent girls and young women, are most vulnerable. And we see this high, the disproportionately high burden of ill health, as well as social and the economic challenges that are encountered at that age. I think I reflected on some of the problems that include issues of, for instance, sexual and gender-based violence, which they encounter in those environments. The issues of vulnerability in them, having additional vulnerability when they make attempts to come out of that situation. So they're trying to make a living, for instance, they're trying to earn and get themselves out of that situation. And unfortunately, they miss out on school, and their vulnerability gets enhanced. And some of the issues that are coming up now, which are often not neglected, I think not many people have talked about issues of menstrual hygiene and the needs that are there. Some of these, unfortunately, because of tradition, at times people use culture, they become taboos and they're not talked about. There is an assumption that what is required by the most affluent in terms of meeting their sexual and reproductive health needs and rights, that's more or less taken for granted. And there is the tendency to forget that in those situations, they also require the same services. They also require the same products. They also require even more information on how they can deal with those issues, how they can manage that plight, when they get pregnant, when they have no access to contraception, how do they manage that pregnancy, and how do we ensure that they do have. So that whole issue of disproportionate disease burden or exacerbated social ills, that's actually something which, when you stratify by age, you see. And I did give the example of the global targets, how very often with global targets, as countries, we are very happy to say, yes, we have attained this. Our MC, modern contraceptive use rate, is at that level, at the national level. But when you do the disaggregation, you actually see that those groups are nowhere near even the highs of 30%. I mean, we see it in slums in Nairobi, we see it in slums in Nigeria, we see it in slums, just from the literature that's been published. That's very prevalent. So thank you for raising that important question. We need to emphasize the issue of enhanced vulnerability.
Uh,
I think we have one more question. Huda, do you have a question?
I think just to add to one point that we did check through our multivariate analysis, but age did not come as significant. But still, I believe that probably the sample size is huge. So therefore, probably if we can look at only by age group, we can find it much better. But really it is not showing any significant because we have tested with controlling age, parity, religion, caste, and all those indicator in the background variables. Thank you.
Hello? Yep. Thank you so much. No, this was a really, really great presentation, and kind of to Nomi's point and the great points everybody was making, I think when we look at a lot of summary reports, it's easy to just categorize by urban and rural, and I think everybody here has really hammered in that point that you can't just treat urban as like one group. And I think that's something that's just gonna, at the global level, I think it's gonna be really key. And with the Ugudanga partnership, there was a really interesting slide. I thought from the 0 to 9 migrant group, the education level was actually pretty high. So I was pretty, I love to kind of dig into that. So Brad, I had a quick question for you. The data you presented was so rich, a lot of really great information, and you explained the difference between reversible and irreversible when it was held for education, but you didn't see that change for wealth. Did you look at why that didn't happen in wealth? You explained why it did happen in education. Why didn't that same kind of reversible, irreversible shift happen on the wealth side?
And I know we're getting close to time, but if I understood the data, and Sheikh, do you have a comment? Did you have a question? Yeah. So very quickly, I was curious if there was a quality issue. I know, was there, so for the uneducated who had higher, if I'm remembering the data correctly, higher permanent methods, is there an issue of quality, of care, of perhaps coercion? I'll just say it. Thank you, Julia. Was that something that you were able to dig into with the data? Because it was quite stark. So before you answer, let's turn to Sheikh just as the last question, and then we'll have the two of you close out the panel.
Okay, thank you for your presentation. It's very interesting. And that access to contraceptive services is a big issue in Senegal, particularly in Dakar. And I like the presentation of Burkina Faso because we have the same problem, the same in Dakar. And I want to know in India or in Zambia, what kind of intervention or strategies we can make to make access services to this population?
Yeah. So to your question, yeah. So we saw that reversible and non-reversible, there is a difference by education. So this is actually education plays a big role in their mindsets that what they adopt early. And because in India, our program is majorly dominated by non-reversible method. So therefore, I think, so education actually plays a role, but actually wealth do not factor and education override that. So that is a trend we have seen from the past. But to your question, I think, yeah, one thing is that for service delivery now, earlier it was rural centric. Now in urban areas in India, particularly under this National Urban Health Mission, government is really expanding the services in grassroots level, particularly establishing integrated health services for all services. I think that is making really good sense that when women goes for any service, so they also get to know about other services, what is available in a same premises. and also really access other things. I think so that under grassroots level health and wellness center established by Government of India across urban and rural areas is making a lot of difference in terms of minimizing the gap of services in rural and urban areas. I think that is something is working very well. Thank you.
So just to add to what my colleague has said, in that community outreach in response to your question, that's very important. I think to wait for people to come to services, especially for those that feel marginalized and those that feel stigmatized, they will not. And when they come, it's too late. It's too late when you look at all these indicators, whether it's in need of family planning or pregnancy care or screening for, say, some of the cancers we know tend to be prevalent amongst women, which can be prevented if caught early. So, yeah, in Zambia, I've been fortunate in that the Minister for Health chairs what they call the Inter-Regions Coordination Committee, where partners are brought together to give advice on, the directorates present the progress they are making, and then the comments come from partners. And one thing we've emphasized to say, even in the health budget, it should not just be targeted to the structures, because these people that come to those structures are those that are aware and come and utilize them. And we forget those that are in the communities, where we really need to go to the communities with services, with information. So I would underscore community outreach. The second I would underscore, very similar to my colleague here, is integration. We are seeing efficiency gains from integration. A woman or even a girl can come and never mention, she may come and say, I want a method to protect myself from an unplanned pregnancy. So she'll get a method of family planning. But something she will not mention is that I'm also at risk of an unexpected infection. And so if you integrate those services, if you offer them in where proactively you are able to establish what else the needs are. We are seeing, and we actually have data where we're seeing the benefits of integration, whether it's with HIV and SRA. The last point is education that combines with health services. And this is something we've been able to do now after we've shown the data that when the community, when your outreach programs go to schools and when the facilities are responsive, you have young people who are in school who go to those facilities. And for Zambia, we have demonstrated that even the two ministries are now speaking. They are now talking because they've seen the outcomes related to that data in terms of reduction of early unintended pregnancies, for instance. Thank you.
Thank you so much. Well, we started out with a very small crowd here, feeling we were very marginalized here in the basement. It was such a rich and robust discussion. Thank you. Let's just give a quick round of applause to the presenters for your incredible